lecture is the sacral plexus block, and I have to do it fast, unfortunately. A very important part of the sacral plexus block is the sciatic nerve block. Sciatic nerve block, sometimes proximal sciatic nerve block alone, can do a very good anesthesia for the for knee surgery. Okay, most of the times we add the sciatic nerve block with obturator and the femoral nerve block for knee surgery, just like the total knee replacement, for example. Sciatic nerve block also used for hip, thigh, lower leg, and foot anesthesia. Usually, when you do sciatic block, you anesthetize the posterior femoral cutaneous nerve. Depending on the approach. For parasacral approach, assure this, but sometimes it's variably blocked. It's not always the case to block the posterior femoral cutaneous when you block the sciatic nerve. The drawbacks of the sciatic nerve block: it fails alone with medial foot and leg anesthesia. You have to add saphenous or femoral nerve block to sciatic block to accomplish below knee anesthesia for the medial foot and leg. The motor part of the sciatic nerve block is the plantar dorsiflexion. Okay, now there are many approaches for the sciatic nerve block. You can find the sciatic nerve behind the lesser trochanter, posterior to femur, between the adductus and the gluteus muscles. Okay, so again, behind the lesser trochanter. Okay, posterior to the femur, between the adductors and the gluteus muscles. Many approaches for sciatic nerve block: the posterior, which is the classical Lapet sciatic nerve block; the anterior, subgluteal, and popliteal. I'm going to go fast over two of them and put videos for another two. The lateral position, with the side of the block in the non-dependent area, is the side to be blocked. Okay, so the patient is asked to bend the knee and the affected leg toward his chest, and this is the Sims position. It's called the Sims position. We have to localize the three things: the greater trochanter, the posterior superior iliac spine, and the sacral hiatus. Okay, a line is drawn between the greater trochanter and the posterior superior iliac spine. Then at the midpoint of this line, we draw a perpendicular line, and the second line is drawn between the greater trochanter and the sacral hiatus. The intersection between this line from the previously mentioned line and this line between the greater trochanter and the sacral hiatus is where you inject your local anesthetic. A perpendicular needle is inserted, 10 centimeter needle actually, at angle perpendicular to all the planes of the skin. Okay, then the needle is advanced through the gluteal muscles. What the motor response to expect is the plantar or dorsiflexion. Okay, then a local anesthetic 25 ml is injected in this area.
I will give saphenous nerve block plus sciatic nerve block. Go to the screen. Mention the adductor canal.
This is the adductor canal.
See the pulsation
of the
artery. This is the
adductor canal.
apex of the femoral triangle.
Yes.
And go further angle and go to the sciatic nerve. See the sciatic nerve.
This is sciatic nerve.
Okay. We have three compartments: anterior, middle, and posterior compartment. Now the sciatic. This is the femur.
This is femur.
Okay. I scan down. You can see the pulsation. شو اسمه؟ أحمد داخل. ما عندك شيء بعد
ما عندك أي يا محمد إن شاء الله.
The target now is the sciatic nerve to this patient. Now this is the needle and thread. خرب حمودي هنا. Straight. See the clip? See, that's a little bit of stick. Hello. Straight. See this okay? More. See, okay? Yes, yes. Alright. Straight. Straight. That's it. How many is
Yeah,
total?
25. Both.
Now I will go to longitudinal. Now see the nerve. This is the nerve now. Now can I stick above it? I will go. Longitudinal. See the local anesthetic within the nerve? خلاص. This is the local anesthetic. This is the nerve and longitudinal.
For the subgluteal sciatic nerve block, the patient is placed in the prone position. The block is performed just below the gluteal fold, for it is here that the sciatic nerve occupies its most superficial position and is therefore amenable to ultrasonography. The adductor magnus muscle, the short head of the biceps femoris muscle, sciatic, the long head of the biceps femoris muscle, a 38mm linear probe at a frequency of 13 MHz was used. For this approach, we use an out-of-plane technique. Because the sciatic nerve is a large nerve, it is often difficult to surround it with local anaesthetic with a single injection, and therefore a multiple injection technique is used.
No time to attach a video to put a video on popliteal sciatic nerve block, but I will attach it with the lecture. The popliteal plus femoral is an excellent anesthesia for medial leg and foot. Okay, popliteal sciatic block plus the femoral is an excellent way to anesthetize medial leg and foot. Posterior to the popliteal fossa, we have two divisions of the popliteal, the common perennial, and the tibial. But before mentioning that, I should mention that the popliteal nerve block spare hamstring muscles, allowing lifting of foot with knee flexed. So it's better for ambulation. Now again, posterior to popliteal fossa, proximal to popliteal fossa, lateral to the artery and vein. In the femoral area we have vein, artery, nerve, but here we have artery, vein and nerve. Lateral to the artery and vein we have the nerve. about 2 to 6 centimeters deep to the skin, we can find the two branches, the tibial and the common peroneal. The tibial nerve will also divide into the posterior tibial and sural nerve. Okay, the common peroneal will give sensation to the lateral upper part of the leg. Okay, this is the common peroneal, to the lateral upper part of the leg. The tibial will give us the posterior tibial and sural nerve, which we'll talk more about them in the ankle block. We mentioned this is the sciatic nerve proximal to the popliteal fossa. It divides into the common peroneal nerve, supply the lateral upper part of the leg, and the tibial nerve, and the tibial nerve divides into the posterior tibial and the sural nerve. Okay, sural nerve, and this is the common peroneal nerve, the branches of the sciatic nerve. So the popliteal approach will be attached with the video. Here we can see the nerve supply, the area with the nerve, common peroneal, saphenous, medial part of the leg and the ankle, the superficial peroneal, the sural nerve, okay, I will mention that in the ankle block. The ankle block, which is an excellent block for foot. The advantages of ankle block that it is fast, with low cost and low need for technology. You have to avoid two things in ankle block. You have to avoid epinephrine and excessive volume, because you're dealing with a contained small area, and excessive volume and epinephrine can lead to limb ischemia. In ankle block, we block 5 main nerves. The saphenous nerve, which is the only one that's not a branch of the sciatic nerve, okay, and it supplies the anterior medial sensation of the superficial foot. We find the saphenous nerve anterior to the medial malleolus, as you will see in the next video. The second nerve, the common peroneal, I showed you in the previous graph. The common peroneal will subdivide into the anterior peroneal, okay, and superficial peroneal. The anterior peroneal will enter the ankle between the extensor hallucis longus and the extensor digitorum longus, lateral, just lateral to the dorsalis pedis pulse. Okay, here we have to inject for the anterior peroneal nerve. The motor function of the anterior peroneal is the toe. It's a toe extensors, and it provides sensation for the first dorsal whip space of the foot. Now the second, so the common peroneal, the anterior peroneal, and the superficial peroneal. The superficial peroneal provides sensation for the dorsum of the foot and toes, and the motor function of the superficial peroneal is the eversion of the foot. Where do we find it? We find it in the lateral compartment, lateral to extensor digitorum longus. So the anterior peroneal, we find it between the extensor digitorum longus and the extensor hallucis longus, lateral to the artery, okay? But lateral to the extensor digitorum longus, we find the superficial peroneal. So the saphenous, not part of the sciatic. The common peroneal divided into the anterior peroneal and the superficial peroneal, and I told you where to find them. The tibial nerve will give you the posterior tibial. The posterior tibial will subdivide into the calcaneal, the lateral plantar, and the medial plantar, provide sensory to the tip of the toes, to the heel, to the medial sole, and part of the lateral sole. And the rest of the lateral sole will be supplied by the
malleolus,
sural nerve.
the anterior tibial artery,
you find it between
extensor hallucis longus tendon,
and the
medial malleolus. First, you are blocking the posterior tibial nerve.
And it provides sensation to the
posterior tibial artery
foot,
is marked, and close to it, the needle is inserted midway between the skin,
the saphenous,
and the bone,
superficial peroneal, anterior peroneal, posterior tibial, and sural nerves.
Local anesthetic is
so now please watch this video about
administered here. the bone, and about 3 to 4 ml of local anesthetic is administered here. Medial to the anterior tibial artery and between the extensor hallucis longus tendon, needle is inserted till a giveaway sensation is felt. Once the needle is below the flexor retinaculum, about 3 ml is blocked to block the deep peroneal nerve. About 1 centimeter below the lateral malleolus, the needle is inserted perpendicular to the skin to a point midway between the skin and the bone, and about 3 ml of local anesthetic is administered to block the sural nerve. A subcutaneous infiltration to block the saphenous and the superficial peroneal nerves is being done now. This is done between the two malleoli. A total volume of 20 ml may be required to block all the nerves.
Okay.